difficult times. We at Bengal's Tooth Saviors are back with our eighth webinar on one of the worst nightmares of healthcare sciences, squamous cell carcinoma and its precursor in oral cavity, the challenge before modern day medicine. Today we have the gracious presence of our guest speaker, Dr. Major Polash Kumar Mondol, Associate Professor, Department of Pathology in College of Medicine and Sagar Datta Hospital, and currently attached to Desan Hospital. Dr. Mondol has been in the Army Medical Corps serving the nation for several years and has been an eminent professor at North Bengal Medical College and Medical College, Kolkata. Besides leading innumerable conferences across the country, he has served the humanity for over 3 decades. One of the gemstone and stalwart personalities of modern time, he has been the most favorite and the charm of the department among the students. A prolific doctor and teacher par excellence, we are extremely blessed to have him today among us. This is your host of the day, Rajdeep Samadar. Now I would like to invite Sir to take over the proceedings. Over to you, Sir.
Thank you, Rajdeep, for the kind introduction. I am humbled. So, without wasting much time, I think I should start presenting. My computer is showing Shagnik Sannal is presenting. Can he? Uh, okay, now. Fine.
Yes, sir. You can continue.
Okay. Can you see my full screen now?
Yes, sir. It's visible.
Okay. Good afternoon, ladies and gentlemen, my dear students and faculty members who are present today for this seminar or webinar, as you may say. So, as I discussed with Rajdeep, to present before you a pertinent topic, which is the challenge of the century. Carcinoma or any malignancy is one of the most difficult areas for a medical practitioner. Why? Because see, I when I was in Thakurpukur Cancer Hospital, there was a common saying, cancer has no answer. Well, that scenario has changed quite a lot, but still malignancy is still remains as an enigma before the medical fraternity. So to find out one of the most important malignancies related to oral cavity and one of the important malignancies which is causing increased morbidity as well as mortality in India and its subcontinent, we start with the discussion of squamous cell carcinoma and its precursor in oral cavity. The cursor is not moving. Just give me some time. I think it happens. It has happened before also with me. Just give me some time.
Okay, sir. Sure, sir. No problem.
Sorry about it. Just bear with me. I'm trying to come into the.
Sure, sir. Take your time.
So this is our college. As you all know, it is a full COVID hospital these days, and except some maternity cases and some pediatric cases, almost all the patients are COVID patients. And even from the department of pathology and other pre and paraclinical subjects, we have to go and be present in the wards and do the clinical evaluation and give the rounds of these patients uh, on a regular basis. I pay my homage to the COVID warriors who have died in this fight against this dreadful disease, as well as the normal people who have succumbed to this disease. And I also pay my homage to the defense personnel because they are working day and night to keep our borders safe. And as you know, even yesterday also in Kashmir, 4 army personnel, including one officer, was killed. So I always am grateful that I was part of the Indian Army. So today's learning objectives, we will discuss the topic under the following headings: cancer, its scenario in India and the world; benign lesions of the oral cavity, we will discuss mostly squamous cell papilloma; precancerous lesions, what are they? Leukoplakia, erythroplakia; squamous cell carcinoma proper. Of the oral cavity only we will discuss what are the basic types, the classic type and the HPV associated subtype; the pathogenesis and molecular biology of the disease; and finally the lab diagnosis. Because without diagnosis, nothing happens. Now, the 5 most projected cancers in 2020 in India for males are lung, mouth, prostate, tongue, and stomach. See, out of these, two belong to the oral cavity, the mouth and the tongue, and it constitutes almost 36% of all cancers. In females, breast cancer is the commonest cancer, followed by cervical cancer, ovarian cancer, uterine, and lung cancer. 95% of the head neck cancers are squamous cell carcinomas. So if somebody is suspecting a malignancy in head neck region, 95% chance are that the malignancy will be squamous cell carcinoma only, and the rest may be adenocarcinomas, melanomas, and other rare entities. And HNSCC, that is head neck squamous cell carcinoma, is the 6th most common neoplasm all over the world. Now, why are we discussing all this? Because you see, the 5-year survival rate for early stage oral cancer is 80%, whereas for late disease, it becomes only 19%. That is why we need to diagnose all these lesions very early, before they have become full blown, before they have metastasized. We have to catch them young. Okay. And you know, in skin, it can arise from various lesions, and there are various damaging factors like the sun, which leads to actinic keratosis and the Bowen's disease. The burns, there is a ulcer which occurs especially in the burn area, that is known as Marjolin's ulcer, and it is also one of the precursors of malignancy, that is squamous cell carcinoma. But we will not discuss Marjolin's ulcer, Bowen's disease today, because we will confine our talk to the oral cavity. Otherwise, it will be a very, very big topic and people will lose interest also. So coming to head neck squamous cell carcinomas, what we have found out that why they are so important is that not only the primary tumors, there are some secondary primary tumors also which are reported to be higher than in other malignancies of the body. What does it mean? It means that a person, suppose, is having a squamous cell carcinoma of the tongue. He may develop another squamous cell carcinoma as a primary, not as a metastasis in another region, suppose say larynx, or in any adjoining region of the head neck. Okay, so this is known as second primary tumor. You have to understand these things, because it is not I have gone a little out of your BDS topic, and make it as a made it as a comprehensive topic. And even I don't know if any oral pathologist is attending today's lecture. I have included some topics which will be even essential for uh, person who is studying MDS in oral pathology. So basically, this particular concept is known as field cancerization. What does it mean? Multiple individual primary tumors which develop independently in the upper aerodigestive tract. Okay, so there are multiple primary tumors which have developed. One is not related to the other. They are on their own primary tumors which have developed in the upper aerodigestive tract as a result of chronic exposure to various carcinogens. You know, we are exposed to lots and lots of carcinogens with the urbanization, with the deforestation, and nature has its own way of revenge. You cannot deny that. You try to sideline nature, and nature will come back and punish you. That is what we have seen in the recent past. So many things are, so many incidents are there. So whether you agree or not, it is a way of nature's revolt or revenge. Okay, so that is why all these deforestations, all these urbanization are posing an increased risk of cancer for all of us, starting from uh, the emission from the vehicles, emission from the factories, the pollutants, the pesticides. Everything of today's world has some risk of malignancy. So that is why this is very, very pertinent. And uh, as practicing dental doctors, you should be aware of these things. You should be aware of the holistic nature of the disease and not just confine yourself to a particular area. Okay, so broaden your horizon. I would always tell my students, whether be it medical students, MBBS students, dental students, or even the technical students, we teach DMLT students and other technical students also, to broaden their field of knowledge. Okay, you never know when it might come handy. So ultimately, the crux of the story is that you have to catch them young. Catch them young means you have to detect the malignancy as early as possible. Okay, so for that, there should be some screening programs. There should be some uh, community based programs which will enable the persons at risk to be identified, the persons who have already developed some pre-malignant lesions or precancerous lesions, or the persons who have already developed malignancy but are shy to show it to the doctor. Okay, what happens is that, you know, the lack of knowledge amongst the general population leads to the spread of this disease. I have been associated with malignancy for quite some time. I was there for 8 years in uh, Akurpukur Cancer Hospital, which is known as Saroj Gupta Cancer Institute and Research Center. So, and I have also been trained at Tata Medical Center, Kolkata. So, where I have with all these places, what I have seen is that most of the people, especially in our country, from the semi-urban and rural areas, come quite late. They keep on showing to the local doctors, who are either not able to diagnose the disease properly, or they keep on delaying by holding the patient, which is a very, very wrong practice. The crux is that the person comes to you at a very, very late stage. And as you know, once the disease has spread beyond a certain area, the mortality becomes very high. Even with the most advanced therapy, the mortality cannot be reduced. Okay, so please remember, always be suspicious of a particular lesion. Don't ignore it. If a lesion is there, try to look into it. Try to look into it with all the angles. Okay, don't brush it off. Oh, that it is a minor thing associated with some betel nut or a teeth injury. So don't ignore it. If you think it is a minor lesion, okay, follow up the patient. If you think it is a risky lesion, send it to a person who is more uh, who has more experience than you, and then so that the person may be treated in a better way. Coming to the benign lesion, I will only discuss one benign lesion, that is squamous cell papilloma, which is also in the syllabus of your BDS dental program. So what are these? They form a range of localized hyperplastic. Hyperplastic means which have become big. Hyperplasia means more number of cells are there. So that is called hyperplasia. There is something called hypertrophy. Hypertrophy means the size increases due to the increased size increases because of the increased number of cells. So this is localized hyperplastic exophytic. Exophytic means it is protruding outside the epithelium. Okay, like finger-like projections. You see here the lip lesion. Okay, you see they are protruding outside the lip. All these are papillomas. And polypoid lesions of the hyperplastic epithelium with verrucous or cauliflower-like morphology. This term verrucous, you have to know what is verruca. Verruca means what? What it has got a rough appearance, like the head of a cauliflower. Okay, so cauliflower, as you know, has multiple small flowers, giving it a rough appearance. It does not have a smooth appearance like a cabbage. So cauliflower's morphology is that of a wart. It is called, general terminology is wart, and the medical term or uh, the term for this is squamous cell papilloma. And it is where it is found. It is found on the surface of the skin, that is epidermis, and also in the passages of the respiratory and digestive tract, and it is even found in the genital organs also, and in the lining of hollow organs of the body. Even in the genital organs, it is found as a squamous papilloma. At times it changes its shape, becomes malignancy, and it is mostly associated with a virus which is known as human papilloma virus. Okay, various subtypes are there. Some subtypes are associated with benign morphology. Some subtypes, like that in cervix, are associated with malignant morphology. Especially 16, 18 subtypes are there, which are of whenever those subtypes are present, they pose a increased risk for malignancy. Okay. Now coming to the precancerous lesion. What does this term precancerous mean? Means a lesion which will definitely lead to malignancy if it is left like that. So that is the meaning of precancer. So one of them is leukoplakia, and WHO has defined leukoplakia as a white patch or plaque that cannot be scraped off and cannot be characterized clinically or pathologically as any other disease. Okay, any white patch is not leukoplakia, but a white patch which cannot be scraped off, যেটা আমি বাংলা একটু বলছি, যেটা যেই হোয়াইট প্যাচটা তুমি সরাতে পারছো না, চেষ্টা করছো সরানোর with your spatula or whatever, you're not able to scrape it off, that white patch is suspicious and you have to term it as leukoplakia. It is different from the fungal entities like candidiasis or lichen planus, which are not leukoplakia. Okay, so you have to be, as practitioners of dentistry, you have to know what is exactly leukoplakia, because all white patches are not leukoplakias. There are some patches which are benign and which are not related to leukoplakias, and there are some patches which are definitely leukoplakias. And your duty as a practicing doctor is to identify, and then you have to take some tissue from there, so that the final diagnosis is done by the pathologist. It may be oral pathologist, it may be general pathologist like us. So the diagnosis should be there. Okay, and WHO says that until it is proved otherwise via histological evaluation, all leukoplakias must be considered precancerous. And out of this, there is a special term called proliferative verrucous leukoplakia, which is even more dangerous. Okay, so of these leukoplakias, PVL, that is the proliferative verrucous leukoplakia, is more serious. Coming to the second precancerous lesion, that is oral submucous fibrosis. This is a chronic progressive condition of the oral mucosa. It is strongly associated with chewing of betel nut, shupuri, which has recently been categorized as carcinogen. So please remember that this betel nut, which we are fond of chewing, is a carcinogen. So be careful. So leukoplakia, how does it look like? It may be a small patch, it may be a larger patch. Okay, it may be a proliferative. This is proliferative verrucous leukoplakia. The last right side. Okay, proliferative means it has gone beyond a certain boundary, and you see a verrucous appearance, a cauliflower-like appearance, a finger-like projections are there on this particular lesion, which makes it more dangerous than the other ones. Okay, locations: buccal mucosa, floor of the mouth, ventral surface of the tongue, that is the lower surface of the tongue, palate and gingiva. They are the common locations for leukoplakia, and they may appear as a solitary or multiple white patches or plaques with sharply demarcated borders. There is a sharp border. You see, you can identify this is the whitish plaque and this is the normal area. So there is a sharp demarcation is there, and you can distinguish the area from the normal area. It may be slightly thickened and smooth or wrinkled and fissures. The appearance may be varied. It may be elevated or it may be warty. Okay, so we have the spectrum of lesions which are actually under the common heading of leukoplakia, but the final thing is that a whitish patch which you cannot remove, which appears slightly elevated, is a leukoplakia. Okay, please try to understand this. My aim of this lecture is to make you understand. Don't have to memorize everything. Try to follow the lecture. Try to understand what you have to do when you sit in a clinic. Okay, ultimate thing lies on you. If you cannot diagnose, then it is your discredit. But if you can successfully diagnose and treat the patient, even if you can't treat yourself, you send it to your colleague, then your purpose is solved. Okay, after seeing it on gross, what do? You take a sample of the tissue, that is, you take a biopsy, and that biopsy is subjected to histopathological examination. You put it in 10% formalin, send it to the path lab, they process it, and make a paraffin block. From there, they take sections, stain it with hematoxylin and eosin stain, and then the slide is ready. Once the slide is ready, it is the diagnosis is of our utmost importance. You have to correctly diagnose. So that diagnosis rests upon the pathologist, be it an oral pathologist, be it a general pathologist, as I told you. So what do you see there? You see epithelial changes ranging for hyperkeratosis. Hyperkeratosis means increased layer of the stratum corneum. That is the dead cell layer, the topmost layer. Hyperkeratosis, that is called hyperkeratosis. Overlying a thickened acanthotic. Acanthotic means the size of the epidermis has increased. But orderly mucosal epithelium, initially they are orderly, means the maturation is normal. The surface has normal maturation. That is, the cells are small, the cells are flattened. That is called normal maturation and polarity. Okay. But gradually they become markedly dysplastic and they become malignant, full-blown malignancy. Initially, they will be in situ malignancy. In situ means which is confined to the basement, up to the basement membrane. The basement membrane, that is the lining between the epithelium and the subadjacent stroma, is called basement membrane. That basement membrane is intact. It is the door, it is the wall which is separating the epithelium from the underlying stroma or the subepithelial region. If that wall is broken, so that is called breaching of the basement membrane. The breaching means bhenge jawa. Breaching means the broken part of the basement membrane, which leads to the entry of malignant cell into the subadjacent region. That leads to invasive malignancy. Initially it was in situ malignancy. However, it became invasive malignancy once the basement membrane is breached. So that is the job of a pathologist. Outside appearance may be may not give you the correct clue whether it has already invaded or it is still inside the basement membrane. Okay, so that is why biopsy is very important. Do not hesitate to take a biopsy when you are suspecting a lesion to be a malignancy or a precursor lesion. Third lesion, sorry, this is third, not second. The third lesion is erythroplakia. It is related to the lipoplakia, but has even higher risk for malignant transformation. Okay, so and there is a subtype which has got features of both, which is known as speckled leukoerythroplakia. So what are they? They look like this. So erythroplakia is a reddish spot. It's eroded. It's not elevated. It's eroded. In Bengali we say khoye geche, means there is some erosion, that the surface has got uh, eroded, means that there is some ulceration. Okay, so that is erythroplakia. Age range is between 40 to 70 years, and male have a higher preponderance for this type of lesion. And as you know, the etiology of all these commercial carcinomas and the precursor lesions, that is multifactorial. No single factor is responsible. If a person is having tobacco only, the chances are increased but less. But if a person is having tobacco as well as alcohol, the chances become more. If the person is having a hereditary risk factor for malignancy, the chances become even higher. So that is why it is called a multifactorial disease. Okay, and as you should emphasize, and I think all of you are emphasizing to your patients, uh, though you are not practicing now, I mean the proper the dentists who are practicing. So who are practicing, they definitely uh, tell the patients to have a good oral hygiene. So everything is related. If the person has a good oral hygiene, the chances of HPV infection are little low. Okay, so that's why all these are related. So this is called multifactorial causation. Understand? Hygiene, diet, everything are linked. Now in today's this arena where we are having increased number of COVID patients, so we are always telling to boost up the immunity by taking vitamins, by taking zinc, and so on. So why? Because it gives resistance to the infection. It will not cure the disease, but it will make you more resistant towards the infection, and also make the disease to heal faster. Okay, so that is why we the doctors and the general ICMR people are insisting that you take proper diet, take good amount of vitamins, so that you are immune to the disease process in general. Same is with malignancy also. If your immunity is strong, if you are following good hygiene, good diet, the chances are that even if you have a disease, the progression will be slower. The uh, the I mean the metastasis and all those will be slower. Okay. And what do you see here under the microscope? There is an ulcer, and there is also this subepithelial inflammatory reaction, means the lymphocytes, macrophage, along with that vascular dilatation is also seen when you see the slide of the erythroplakia. Okay, and dysplasia is always there, whether it has gone to carcinoma in situ or squamous cell carcinoma proper, depends on the stage of the disease. Okay. Now coming to the most important topic, that is squamous cell carcinomas. As the name implies, they arise from the squamous epithelial lining. There is a spelling mistake. This should be squamous epithelial lining. My mistake. Okay. So squamous epithelial lining, and initially, as I was telling you, that they are locally confined. There are various grades of dysplasia, and finally they become carcinoma in situ. That is full thickness dysplasia is there. That is called carcinoma in situ. And once the lesion has breached the basement membrane, it is referred to as invasive squamous cell carcinoma. Okay. So you see why this has happened. It has not come from outside. It has come from the oral cavity malignancy and come out through the buccal mucosa, through the cheek, and look at the condition of the patient. Okay, why it has happened? Because of ignorance, because of uh, just ignoring the disease, that it will go away by not taking proper medications or proper precautions or proper treatment for the disease. The person kept on thinking or taking some local medications. So many, I should not be telling you this at this August forum, but I have seen that many patients have at Thakur Poker Hospital used to tell that we had gone to homeopathic doctors and they kept on telling us that they will cure the disease. Eventually, especially the breast cancer patients used to come with widespread metastasis. So since government has recognized homeopathy, Ayurvedic as specialized branches of practicing medicine also, but you see there are limitations. You should understand the limitation of yourself as well as your division. You should make the patient most important person, not yourself or your division. That is the crux of the story, is that you should, the patient is the most important person who has come to you. He is like a god, so you have to treat the person and not treat your ego. Understand? If you are not able to treat, if you think you cannot cure the disease, it is better you send to your colleague, you send to the specialized center. Why keep the patient and why let him die? Understand? So this diagram shows where all the squamous cell carcinoma is affected, and the most important ones, the four important areas are shown. One is the floor of the mouth, ventral and the tongue, the base of the tongue, and the soft palate. Okay, so basically the main thing is that eventually is that these lesions, if they are left like that, they will metastasize. Metastasize, firstly they will infiltrate the local areas. As you saw in the picture, it has gone beyond the mucous membrane and come out of the skin. They will go into the lymph node, the nearest lymph node. The cervical lymph nodes are the nearest lymph nodes which are available to the oral cavity, near the oral cavity. And there can be also distant metastasis, like in mediastinal lymph nodes, lungs, livers, and bones. There, the livers and bone metastasis can be through hematogenous route. Okay, mostly the metastasis of carcinomas are through lymphatic channel. Okay, that is the lymph nodes are affected. But whenever they are involving the organs like lungs, liver, and bones, that is through the hematogenous route or the venous channel. Okay. Now coming to the pathogenesis of squamous cell carcinomas, as I told you, they are multifactorial, means no single factor is responsible. The chronic abusers of tobacco and alcohol are at most risk for this disease, and certain diseases, certain other risk factors are like radiation, that is sunlight, actinic radiation, pipe smoking, that is the people who smoke pipe. You must be knowing what pipes are. So these pipe smokers and even normal smokers who are smoking these cigarettes and BDs and all those things, so they are having increased risk for developing the cancer of the oral cavity. Even chewing of betel nut, especially the betel nut, that is the supudi, and the pan, which is also a risk factor, which has got carcinogens. Okay, and 50% of the oropharyngeal cancer, especially the cancer of the tonsils, have oncogenic variants of HPV, that is the human papilloma virus 16 and 18, which are most responsible for cervical cancer, are also found here. Okay, so based on this HPV association, the whole squamous cell carcinomas of oral cavity has been divided into classic type and the HPV associated type. Okay, because the HPV associated head neck squamous cell carcinomas do better than HPV negative tumors. That is why. Understand? So don't make a generalized statement. So there are differences between even individual squamous cell carcinomas. So for that, what do you have to do? You have to go for specialized testing. Understand? If you don't have that testing facility, send it to a hospital where those testings are done. So HPV detection by DNA method, either by PCR method or by fish method. So those tests have to be done to confirm whether the squamous cell carcinoma is associated with HPV or not. Okay, because HPV containing cancers do not show P53 mutation. P53 is known as the tumor suppressor gene. Okay, so tumor suppressor, it suppresses the tumor. So if P53 is mutated, so that tumor suppression action is lost. So there is that gate through which the tumors can enter becomes open and the tumor will go fast. Understand? So that is why, but just not a single factor is responsible. As I told you, not a single mutation is responsible. Multiple mutations at multiple levels, they ultimately combine together and throw the person or push the person towards malignancy. Understand? You have to understand this basic uh, concept of malignancy. No single factor is responsible. There are carcinogens which are the inciting factors. They're the risk factor. Ultimately, they lead to what? They lead to some mutations in the genes. Mutations in the genes, those mutations in the specific genes like tumor suppressor genes, the gatekeeper genes, the tumor DNA repair genes, all these genes are there, which you have studied in the chapter of neoplasia. So these genes, if they are mutated, then the stoppage of neoplasia cannot happen. The neoplasia cannot be stopped. Eventually, the neoplasia will progress, and once the neoplasia or the malignancy starts progressing, it will not only destroy the local area, it will go to different areas and destroy the function of those particular areas. A tumor, if it goes to lung, it will block or stop the function of lung. Initially, it is a small metastasis, but gradually it enlarges there also. So it becomes the lung function is compromised. It goes to the brain. There, the brain's function is compromised. It goes to the kidney, liver. So all the functions of the particular organs are compromised by the malignancy. Understand? So that is why malignancy is such an important enemy of today's world. The good thing about is that ill-fitting dentures, jagged teeth, or chronic infections do not pose a direct risk. Okay, there was at time theory that ill-fitting dentures or the persons who had this rough teeth or which lead to teeth bite, okay, in the buccal mucosa, that may pose risk factor, but that claim has not been substantiated. Understand? But still the theory of chronic irritation remains, which can be somehow lead to cancer, but the risk is very small if other factors are not present. Okay, if other risk factors are not present, just an ill-fitting denture, just a jagged teeth will not lead to cancer. Am I clear? Now, molecular biology, as I was telling you, based on the HPV association of a particular squamous cell carcinoma, the disease has been broadly categorized into classic subset, that is the classic squamous cell carcinoma, that is only with the oral cavity, not others. Okay, classic subset and the HPV associated subset. The classic subset, there is involvement of the P53 mutation, whereas in the HPV associated subset, P53 mutation does not take place. So that is why HPV associated squamous cell carcinomas are considered to be a little better. It is still a malignancy. Don't think it is not a malignancy. Still a malignancy. It will still metastasize and do all the damage. But still, if you compare vis-a-vis both these categories, HPV associated is a little better. Okay. And since this classic subset has P53 mutation, they are also responsible for the mutations in P63 and NOTCH1. These are the other genes which are all, there are multiple genes which are involved in the cell cycle. And the cell cycle, if the cell cycle is disturbed, It is the most important thing which leads to malignancy, because once a cell doubles, then again doubles, then again doubles, that is the basis of neoplasia. The growth of a cell, uninhibited growth of a cell. The body does not want the growth, but it is still growing. So the cell cycle is ultimately the area which is regulated, and if that regulation goes haywire by mutations of specific genes, then malignancy goes on. Am I clear? Please try to understand. This is a webinar. This is not a theory class for you, but just to have an understanding of the disease. You may even remember and you can write it down, but it is very important for you to understand the basis of the disease, how malignancy happens. Okay. Now, HPV associated squamous cell carcinomas, they contain fewer and very different genetic alterations, and they typically overexpress P16. That is a gene associated with a cell cycle, again cyclin dependent pathway, and there is inactivation of P53 and RB pathways. Okay, the inactivation is there, but P53 mutation, these are very I mean, once you go into try to understand what does this mean, so you have to go into the intricate things, that though the pathway is inactive, but still it is still it is I mean, the genetic mutation is not there in P53 pathway. It is not acting, but it is not mutated. But here the P53 is mutated. Okay, so this is the difference, that P53, it is mutated, it cannot act in any way. But here P53 is not mutated, it is active, it is normal. But some other genetic mutations are not allowing it to act, not allowing the RB gene to act. Okay, so those are the tumor suppressor genes. So they are not able to act, that is fine, but they are normal. In the upper case, before the other case, the P53 is mutated. They cannot function in any way. Okay, so here if the other genetic uh, pathways are not so active, so these pathways can still function. Okay, so that is the difference between these two. Though P53 is not able to act in both the things, but here is a basic difference, is that the P53 remains normal in HPV associated squamous cell carcinoma, whereas the P53 is mutated and is abnormal in classic subset of squamous cell carcinoma. Okay. Now in HPV associated, the first change is the loss of chromosomal regions of 3p and 9p21. That is called loss of heterozygosity. Okay, and there is promoter high. These are all terms related to genetics. Loss of heterozygosity, promoter hypermethylation, and which is leading to P16 gene. That is the inactivation of P16 gene, and eventually, of course, the terminal event. Before the terminal event, there is the mutation of P53 gene, which is actually, then it becomes a common pathway, that the pathways ultimately converge, and there is lastly there is amplification and overexpression of the cyclin D1 gene, which leads to further progression, and the malignancy becomes fully established. Okay, ultimately you see all these genes are involved in various manners. So in the classic subset, the P53 pathway is the one which is affected very early. Okay, whereas in the HPV associated, P53 initially remains inactive and mutation comes very late, and eventually when P53 mutation takes place, it leads to dysplasia. And to remind you what is dysplasia, can anyone tell what is dysplasia? So dysplasia is basically these criteria for diagnosing dysplasia. That is the second table what says. You see there are, this is very important for neoplasia also. The chapter neoplasia has this thing. So what are the first thing? First thing is the loss of basal polarity. Basal polarity means there is a normal maturation of the cells from the base towards the surface. Okay, the basal cells are large, and the surface cells are small, flattened. Okay, so when the basal cells, when the surface cells become larger, then they look like basal cells. That thing is called loss of polarity. Then there is increased nuclear size, that is called high NC ratio. High NC ratio is a term which is a very important term for diagnosing dysplasia. Okay, nuclear size becomes large. Normally nuclear size is 1/3 of the cell size in most of the squamous cells, but if it increases more than half, it indicates that the NC ratio has increased and it is indicator for dysplasia. Then hyperchromasia, the nucleus becomes dense in color. That is, the whenever we are staining with hematoxylin, we are staining with Leishman in cytology, it retains a very dark color. Okay, that is called hyperchromasia. Increased number of mitotic figures. So mitosis is normally not seen in the normal slides. Can be seen, occasional mitosis may be seen, but if you see increased number of mitotic figures and abnormal mitotic figures, abnormal means you can see tripolar mitosis, you can see ring mitosis, these are all abnormal mitosis. So if you see a single abnormal mitosis, that is a malignant cell. Okay, so increased number of mitosis, abnormal mitosis, prominent nucleoli, all these are indicative of dysplastic changes. Okay, so also keratin pearls within retipex, premature keratinization, all these are indicative, but most important what I told you are the abnormal variation in nuclear size, abnormal nuclear shape, that is pleomorphism, that there is difference, one nucleus is different from the other nucleus, that is the abnormal variation in shape. Okay, pleomorphism. Anisocytosis, one cell is small, the other cell is large, another cell is medium, so that is called anisocytosis. Then high NC ratio, nuclear size, atypical mitotic figure, hyperchromasia, all these things indicate there is dysplasia. So cytological evidence is very, very important. Whenever they ask you in the viva that what are the features of neoplasia or what are the features of dysplasia, please remember this cytology. Starting from the loss of basal polarity to high NC ratio, hyperchromasia, pleomorphism, and increased mitotic figures and atypical mitosis, please remember. Then when these are the cellular features, and the surest sign of malignancy is what? Metastasis. When the neoplasia has breached the basement membrane, it goes to the surrounding area. But if it goes to the distant lymph node or a distant organ, it is the surest sign of malignancy. Okay. So these are the pictures which are showing that various from the normal mucosa to the various appearance of the various the malignancies through various grades. Okay, mild dysplasia, moderate or severe dysplasia, then squamous cell carcinoma. Here also, the basic thing you have to understand is that for these are the large cells. Okay, third picture, the large cells look little dark. Here the large cells are confined to the lower part. Here the large cells are actually increasing in their numbers. Okay, they are trying to reach the upper portion, and here they have reached that upper portion also. So here you see all the cells are looking dark and large. Okay, this is a small picture. I mean, this particular photomicrograph is small, and these pictures have been taken from the book. So these are not my pictures. I have told you that I acknowledge that all these pictures have been taken from various books and not my own pictures. Okay, and this is squamous cell carcinoma. You see, this has got a very, very different appearance from this one. Okay, you see the cells are small here. Whenever you come to the higher power, you will see the cells are large, very dark, and they have mitosis, and eventually they will, this lower portion is the basement membrane. You see, this one is the basement membrane. This undulating margin is the basement membrane, and in these elongated ones are known as the reti ridges or reti pegs. So whenever there is a tumor which breaches the basement membrane and comes into the subepithelial stroma. This is the subepithelial stroma. This is the subepithelial stroma. Can you see it? See my cursor, pointer. I don't have a, this is a webinar class, so I cannot show you through a laser pointer. So this is the subepithelial region. This is the epithelium. This is the topmost layer, is the keratin layer, and this layer is called the subepithelial region or the stromal region. So this area, if it is infiltrated by the tumor, that indicates a tumor has penetrated the basement membrane and gone into the submucosa. Okay, so that is again a sign of invasive malignancy. Now coming to all this, eventually after seeing everything, a person has come to the doctor, a diagnosis is done based on the morphological or gross appearance of the lesion, but still lot of things are there which can be a challenge for the pathologist. Why? Because the doctor at the other end is always asking for the report. Hurry, hurry! I want the patient. The patient is becoming serious. I want the report early. So to solve all these things, we have to follow a particular protocol. We should know how to go about diagnosing a particular disease. First thing is that you should have a proper history, because pathologist, as I am sitting in the lab, I am not getting to know the patient. I do not have the access to the patient. I only get a tissue in formalin in a small vial. So, and only written is that biopsy from buccal mucosa or biopsy from growth in gingiva. So that is all I get. But whether the patient has had some addiction, whether the patient had familial history of cancer, so nothing is known. That is why all the practitioners, we keep on insisting and telling our clinical colleagues that please write some history, please give insight to the patient as such, not just the biopsy tissue. Okay, so history is very important. Whenever you write your answer, also start the lab diagnosis with the clinical history. History is of the illness, that is the duration of the growth, the rate of growth, etc., how fast the growth is growing. Okay, so uh, so that is very important, history. Then comes addiction, whether tobacco, alcohol, etc., is there. Also you should ask whether the person is working in a particular environment. Suppose in certain environments there is a lot of smoke, so those persons are more prone to develop a particular type of malignancy. Okay, clinical examination, here comes your role. Local examination, you see the lesion, you see how big is the lesion. Pathologist gets a small tissue, not the whole tissue. The first go, there is only small tissue which comes to him. So clinical examination will tell you how big the lesion is. Is it 3 centimeters? Is it 1 centimeter? Is it 0.5 centimeter? Okay, and you should also see the lymph nodes. So this lady has got cervical lymph nodes. Okay, she may or may not have malignancy, that is a different issue, but we see the elevations, and these are cervical lymph nodes. General examination, when you see a person, always see the whether the person is having pallor. Where do you see pallor? From the palpebral conjunctiva. You ask the patient to look up, pull the lower palpebra down, and you see whether there is the pallor is there or not. You see icterus, where the sclera, whether the person is having yellowish color is there in the sclera or not. Clubbing in the fingers and generalized lymph nodes. You also auscultate the chest, see the abdomen and bony tendon. It's for a generalized doctor I have written, but you should, as a practitioner, don't ignore these things. If you see a person only in the mouth, you will only, your diagnosis will be confined to the mouth. But if you are practice in a holistic way, you will learn more and you will be a better clinician, mind you. Coming to the investigations, blood count does not have a very important role to diagnose a particular thing, but it will give you indications if anemia is there or not, if infection is there. Why? How do you diagnose infection from blood count? The total leukocyte count will be high. There will be neutrophilic leukocytosis. The neutrophilic number will be go up. Okay. So that will be sorry, that will be given by the blood count. Then comes radiology. Very, very important. I practice pathology, so I cannot ignore radiological investigations. So whenever we try to write a biopsy report, we always try to correlate with the clinical features, the radiological reports, etc. So X-ray can be intraoral and dental radiographs. It can be in combination with orthopantomography, and which may help identifying the involvement of the bone. So if the bone is saved, so you can think of the next part, that is the surgical resection of the lesion. Should we sacrifice the bone, that is the mandible or the maxilla, or we leave the bone intact and take out the lesion after from the upper end? Okay. Then comes CT scan, PET CT, that is positron emission tomography, which gives focus of metastasis in the various areas of the body. MRI, which are mostly for the staging of the tumor. CT scan may show the local infiltration, but eventually it is by identifying the number of nodes, by identifying the local extent of the disease, they will help in the clinical staging of the disease, which is eventually important for the treatment part. Okay, our role comes next, that is the pathology department. What do? We do some FNAC, that is fine needle aspiration cytology or scrape cytology. We take some scrapings from the lesion, or the FNAC can be done from the lymph node if it is enlarged. If it is not enlarged, you cannot take it. You can take from the lesion, but lesion FNAC from the lesion, let me tell you, is very, very painful and can lead to a lot of bleeding. So be very careful if you are writing FNAC from the lesion. It is better to take biopsy from the lesion, because after biopsy you can cauterize the area or you can stitch the area, but after FNAC we do not do such stitching and all. Okay, so that's why scraping is preferred for tongue lesions and oral lesions. Then LBC smears. LBC is liquid based cytology. It's a special technique which increases the cell count, that is the malignant cells are seen in a better way. There are cytospin smears also. It leads to concentration of the malignant cells so that we can see it in a better way. Cell block. The cells are made into a paraffin block after FNAC without taking biopsy. That is called cytology. The cells after aspiration, they are put into the formalin, they are made into a cell block and sections are taken, and finally the biopsy and histopathology. So biopsy remains the gold standard for pathologists, because eventually on the biopsy itself, the diagnosis of infiltrating malignancy can be given. FNAC will tell you that is a malignant lesion, but whether it has gone beyond the basement membrane, whether it has reached 2 millimeters beyond the basement membrane, it will only histopathology will be able to tell you. So cytological smear, this is the normal squamous cell, looks like this. There are small dots, bacteria. Okay, so this is a dysplastic cell. You see the nuclear size has increased. That is what I was telling you, the nuclei high NC ratio. This is a keratin pearl. Okay, it's a keratin pearl. These are all cytology smears. These are showing pleomorphism, hyperchromasia. You see, one cell is different from the other. The cells are looking dark. Okay, unlike this one, these cells are also, the nucleus are also dark, but they're very tiny. Here, the nucleus has increased. They are irregular. That is called pleomorphic. Okay, and you see here also the cells, there some of the cells are showing nucleoli also. These are mitosis, which are evident, and this is a poorly differentiated. Then you cannot distinguish whether it is a squamous cell carcinoma or it is an adenocarcinoma. Okay, distinction is very important because treatment lines are different. All malignancies are not same. So you have to, the diagnosis is very, very important. You have to pinpoint the diagnosis and also do some ancillary studies to diagnose if it is associated with HPV or not. And then you can come to a final diagnosis and plan the management. Management is not just giving medicine or just doing the excision. It is a holistic management. It combines the surgeon, the oncologist, the radiotherapist. Everyone should come together and do the management of the malignancy. Okay. The cell block I was talking, these are the cells we have been taking during aspiration, and paraffin block has been made. and it gives such a nice appearance. You see, this squamous pearls and all can be identified very clearly. So that gives an indication that it is a squamous cell carcinoma. And immunocytochemistry. So immunostains are special antibodies which are used to detect particular lineage of a cell, and this gives an idea whether the cell is of a squamous cell type or adenotype, or it has got a high mitotic rate. There are various antibodies. I cannot go on telling you all this because already 1 hour is over. So there are various antibodies so which are used to identify either the lineage or the prognosis of the tumor. So various squamous cell based on the histopathology, the various subtypes are there. Either it is a in situ or invasive, whether it is a well differentiated, moderately or poorly differentiated. This example I was showing you is of a poorly differentiated carcinoma, because you cannot identify whether it is a squamous cell or not. It is a malignancy, fine, but which type? So that is called poorly differentiated. Keratinizing, non-keratinizing. Keratinizing means there are keratin pearls are evident. So this is a keratinizing, and here you cannot see any keratin. This one, this one. So this is a non-keratinizing type. Okay. And histologic, various histologic types are there. I am not going to discuss. These names are only there. Verrucous type, basaloid squamous type, acantholytic type, lymphoepithelioma-like type. So these are the various subtypes of squamous cell carcinomas. I am not going into the subtypes because it will again take a lot of time. So this is what under the histopathology, what we see, normal epithelium CIN is the cervical intraepithelial neoplasm. So that is related to the cervix. We saw the dysplasia here also. So mild, moderate, severe dysplasia here. It is why it is comparable, because there are some similarities between cervical cancer. Why cervical cancer we have taken? Because cervical cancer was at time one of the most important and most cancer causing death in women. Now breast has overtaken it, but still cervical cancer, it is related to HPV, and it is very important cause of morbidity and mortality amongst women, especially in the rural areas. Okay. Now coming to a section like this, you cannot identify what type is it. Is it a squamous cell carcinoma? Is it adenocarcinoma? Is it a neuroendocrine tumor? Is it a lymphoma? So what do? Then we go for immunohistochemistry. So there are specific markers. This NAPSIN A will identify that it is an adenocarcinoma. P40 will identify it is a squamous cell carcinoma. CD56 will identify it is a neuroendocrine tumor or a small cell carcinoma. So like that. Okay. If it is a lymphoma, you can go for LCA, that is leukocyte common antigen, or CD45. So these will indicate the specific lineage of the tumor. Okay. Then ancillary techniques like FISH, which is fluorescence in situ hybridization, that can lead you to identify the specific association of HPV. Okay. And then the molecular method, the PCR and the real-time PCR, the sequencing, the next generation sequencing. This is a PCR machine. This is from, the picture is been taken from Tata Medical Center's machine, where I took my training for a couple of months over there. So, and this is very fast, less time consuming, ease of interpretation, because the computer assists you in diagnosing the particular mutations. Okay. And ultimately, a good pathology report depends on the very good interaction between the clinician, pathologist, radiologist, and all should come together for a proper diagnosis. You should not be a miser. I will not share my knowledge. No, you should share your knowledge so that you can help your colleague to give a proper diagnosis and a better management for the patient. Eventual aim is the patient should get a good management. Okay. Treatment is basically you have to excise the lesion. If the lesion has gone beyond a certain area, you have to do a radical neck dissection. Then radiotherapy plays a very important role in all squamous cell carcinomas. Chemotherapy is very selective. Specific gene mutations, if they are noted, they can be given chemotherapy, but it's still a little dubious area for squamous cell carcinomas. Ultimate message I would like to convey you that you have to diagnose the disease early. That is why we pathologists, we are always there to catch the disease early, but it is the clinician who has to send the disease or send the biopsy or the patient to the pathologist for early diagnosis. Unless you guys take that initiative, you diagnose it clinical, you got diagnose it through your clinical examination, the patient is not going to benefit. Okay, so then comes the treatment and eventually prevention. Prevention is a very important thing. Mass education, mass screening, these are very, very important things. So the awareness that I am I am smoking, so that is harmful for me. That awareness is very important. Even there are doctors who keep on smoking, take a lot of alcohol, even in spite of knowing that it is not good for health, but the mass awareness is very, very important. Okay, so that is how we can win over this disease. If the will is not there, if we cannot sensitize our mass, we will never be able to win over the dreadful disease of cancer. Thank you so much. If any queries are there, I am happy to answer you.
Thank you so much, sir. It was an amazing and nice presentation. Now I would like to request our technical head, Shagnik Sannal, to take over the queries that have received from our beloved audiences.
If there are any queries, kindly address them in the chat section, or you can even unmute yourselves and do the needful as well. Once again, thank you, sir, for such an excellent insight into such an important malignancy.
Thank you so much.
I
Thank
guess
you
we
once
don't have
again,
any
sir.
queries. I guess we don't have any queries. No one has any questions at this point.
Even if you
So
have
we will be
queries, just
wrapping up.
let me know. I will be happy to answer. You have my
Yes,
number. You
yes,
can
absolutely.
send me WhatsApp or ask me. No problem. Okay.
Sure, sir. Sure, sir.
Okay.
Okay, sir.
Okay.
We
Then
are. Hmm. Thank you,
I
sir.
exit now. Okay. Thank you.
Thank you.
Okay. Okay.
Thank you, audiences, for staying with
Thank
us.
you,
Now
audience,
we
for
are
your
wrapping up
kind
the session.
patience, for a lot of patience, and yes, sir.
বল হ্যাঁ ঠিক আছে ও হয়ে যাবে অসুবিধা নেই চাপ নেই ঠিক আছে চল রাখ হ্যাঁ বেরোই
ঠিক আছে, okay, okay.
ওকে বাই